apologize that a few of our fellows are still late. They're probably trying to register or something, but they'll be wandering in.
It's just like in the Brown University classroom.
Yes, that's probably true. And they're probably sleeping, just like some of your students. Not the ones in class, of course. So we have heard from a number of speakers about the relationship between TB and HIV. Dr. Harris mentioned it, also Dr. Reichman, and I think some people yesterday. So we've talked about it a little bit at the margins. Now we're going to focus directly on it, and to help us do that, very pleased that we have Dr. E. Jane Carter. She is Associate Professor of Medicine at Brown University in Rhode Island in the United States. Her work focuses on TB, both in the clinic in Rhode Island and also in Kenya. So she is, again, focused on research and treatment, and thank you so much for being here. We look forward to your presentation.
Oh, well, thank you. And thank you all for being here. So,
I'm sorry. I forgot to mention something very important, which is that in addition to being a professor of medicine at Brown, Dr. Carter is president of the board of directors of the International Union Against TB and Lung Disease, which, of course, is putting together a whole conference. So she can answer all kinds of questions for you.
or I can send you to the right person. I think that's sometimes my greatest attribute. So, but first, I just want to thank all of you for being here today. I think that I'm a clinician, first of all, and I do operational research in rolling out programs. But I think you are the key, because I can do all of the work that I do, and if no one hears about it, then in fact no one knows about it. And so at the university, they always tell us for our academic practice that if you didn't write about it, you didn't do it. And I think the same thing is true in terms of just getting out the stories. So let me see which way I'm going to do this. Okay. This is the outline of my talk, and I'm going to talk about the unique symbiosis of the two epidemics, tuberculosis and HIV. And then we're going to talk about diagnosis, treatment, and then a little bit about programmatic support. So just to give you an idea of who I am, you got a little bit of the introduction, but these are the pictures of my two worlds. These are the 200-year-old gate. Do I have to stand right by the, if I talk loud like an American?
We can listen.
Okay, you can hear?
Is that
Okay.
No.
Oh, okay, perfect. Okay. These are they're called the Winkle Gates. So they're 200-year-old gates to the university where I work in the United States. But I have to tell you, my second home since 1997 has been in Eldoret, Kenya, where I run a my university is part of a medical exchange program with the second medical school in Kenya, Moi University School of Medicine. And so I spend about 3 months of every year there at this point in time. And I actually show you this picture because this gentleman is day 2 of his antiretroviral therapy. He actually came to the hospital, got diagnosed with his tuberculosis, and was HIV tested as was recommended at the time, and was HIV positive. And so he actually took to his bed here and didn't get up for about 2 or 3 days. The house staff, the team taking care of him, would come by every day and sort of, talk a little bit, and then, but nobody had really asked him sort of why he had sort of rolled over in bed and was just looking at the wall. And the real issue was that no one had explained that just outside this window, 2 weeks before we had started an HIV care program dispensing antiretrovirals at the medical school and there. And so in fact, he just didn't think there was care and had given up. This is the second day of his medications, and you can see he's up and smiling, and he actually asked me to take this picture and disseminate his story so that other people would know that there was care and there was hope. And so I just wanted to be sure that you heard about that, because you're the people that I need to disseminate some of these messages. So I know you've probably heard some of the data, but in fact, I can never, there are 2 or 3 slides that no matter where I go, I always include. So why is tuberculosis important? It's the leading cause of death in the world today from a single agent. The leading cause of death in women of childbearing years, not because it has anything to do with reproductive health, but because it's a disease of young adults, primarily. It's the leading cause of death in individuals living with HIV. And 5,000 people die each day from tuberculosis, despite the fact that over 50 years ago, we actually put together the regimen that's life-saving for this disease. And in most of the world, the cost of that regimen is less than about $10 US. So we're not talking about an expensive treatment. 1 person globally is infected every second. So during the course of a talk like this, about 3,600 people will be infected. But as you all know, the epidemic of tuberculosis is not equally distributed throughout the world. It actually preferentially targets, at this point in time, places that have the least amount of public health infrastructure or wealth to devote to care of tuberculosis. And if you look at the maps of HIV, it's always interesting to me how closely these mirror. The high prevalence and high incidence countries are always in the same color. Well, why is that? This is a picture of the dynamics of the 2 epidemics, and these are the same type of curves that actually occur in any population where tuberculosis and HIV intersect. And we like to say that, in fact, tuberculosis is the shadow of HIV. Okay? It turns out that if you are TB infected and have a normal immune system, meaning totally healthy and not HIV infected, your risk of developing tuberculosis disease is about 1 out of 10. If, however, you are co-infected with HIV, the rate at which you go from being TB infected to being TB diseased, instead of being 1 out of 10 over a lifetime, becomes 1 out of 10 per year of life. So if you live with your HIV for 10 years, you have a 100% chance of developing tuberculosis. And so what we see is that in areas where the HIV epidemic took off, such as here, the tuberculosis epidemics take off following usually in about a 5-year time period. So although these are the dynamics of TB and HIV in Kenya, where I've been working, this is the same sort of curves throughout the world. Now here's my other slide of the day that I actually give, again, no matter what lecture I'm giving to, so that we're sure that we're talking about the same thing. Exposure, infection, disease, contagion. And you might have heard these from other people who were talking about tuberculosis, but I always put it in because I want you and I to be talking the same language. So tuberculosis exposure is a piece of history that you might that would take about a person. So I've been a tuberculosis doctor for about 25 years, maybe a little bit longer now. I've clearly been exposed to tuberculosis. I work in a TB clinic in the United States, and I work in TB clinics throughout Kenya, so I'm clearly exposed. Now, does everyone who's exposed to tuberculosis become infected? Well, no. It turns out that within a household unit, where you have the most exposure, about 1 out of 3 people in the household will become infected from the source contagious case. So not everyone who's exposed in the world becomes infected. Infection means that I carry the TB germ within my body. My immune system, for the most part, in most individuals, except in young children, in advanced HIV and in a small population of normals that we don't understand why. Those individuals may get sick very rapidly on time of infection, but for the most part, my immune system will wall off the germ and control it for a period of time. And that's the timeline of tuberculosis, where we say latent TB infection or a TB carrier. I'm not sick. I would not know that I carried the TB germ without some specialized tests, and I'm not contagious to others. Now, of the people who are infected, I was just saying 10% of people will become sick with TB disease. If they are not HIV infected, 100% of people who are HIV infected will go from infection to disease unless they're treated at that point. Okay? And not everyone with TB disease is contagious. Only the lung form of tuberculosis is contagious. Now, most of what I'm going to be talking about the rest of this lecture is when I say tuberculosis, we're going to be talking about TB disease. I'll try to be sure that I go back and say TB infection if I'm going to talk there.
Can I ask you a clarification?
Sure.
So when you say
You can ask any question you want.
when you say 100% of those infected with HIV would
HIV and TB. So they're infected with TB and then they have HIV.
So that's if they're not on ART, or that's if they.
You know, ART, you're ahead of me. I'm going to have to do this. ART for the HIV infected person reduces their risk of developing TB disease if infected, but it never returns it totally to someone with a normal immune system.
Great.
So you're right. Okay. Other questions?
I have a question. Why you don't wear a mask when you were sitting with this infected guy? That's all the time I see that tuberculosis doctors, for example, I'm from Russia.
Right.
They don't wear masks.
Well, you know, I don't wear a mask in when I'm working in Kenya because we just don't have enough masks. Okay. And so for much of the world, it's actually the issue is how much resources you have. Now, you could say, well, you're from Rhode Island, Jane Carter, you could carry a mask over with you, but I'm not going to put that barrier between myself and a patient when I can't explain it well, and I'm not going to do that when I am working with other individuals, other healthcare workers who can't do that as well. We have masks at our site in Kenya when we're dealing with our MDR-TB patients, but other than that, we don't wear masks. Now, what I am doing here is I'm doing what I would call very good infection control. So you think that because I'm not wearing a mask, that in fact I am not doing anything in terms of infection control. Well, the best way to stop someone from spreading tuberculosis is to have the patient on treatment, okay? And every day that the patient takes their medications, their contagion decreases. Now, my colleague Ed Nardell, who's just in the next room at the other meeting I was at, he's actually doing some very nice work in South Africa that actually may even tell us that 2 weeks on adequate therapy stops transmission, maybe even in some of our MDR patients if we have them on the right medications. So the first thing that we always do in infection control is put the patient on medications.
But
Okay.
it's only the second day.
I'm sorry, so this is the second day. So I did, this is the second day. Now, the other thing is, I'm not sure you can see the window there. You know, the other thing that we use in TB is environmental controls. You can't really tell, but those windows don't actually have glass in them in this clinic. So there's actually a slight breeze coming through the ward. And so when I'm actually sitting or talking with the patient and walking onto the ward, I usually actually will put myself in the right position where the breeze is actually going from me toward the patient, away in this way. And the last thing, there is a little bit of sunlight in here. Most of the time we would actually have we had the TB clinic actually outside. Tuberculosis is killed by UV light. The other thing that we do is, in the United States, as a healthcare worker, we have legislation that requires us to be tuberculin skin tested and looking for TB infection. I like to joke that I'm the most TB skin tested person in the state of Rhode Island. Because of my exposures in my work in Kenya, I actually have my skin testing performed every 3 months for the last 20 years. So I am still TB skin test negative. We assume that my immune system works and that test is reliable. But it also just goes to show that just because you're exposed doesn't always mean you're infected. Now, some of that I admit is probably luck, that I try to use what I can. And in fact, we probably are genetically different in terms of our ability to handle mycobacterial disease. So, but yes, you're right. If I was in my clinic in Rhode Island, I would be masked, primarily because that's what we do. Masks, though, are the least effective of our infection control measures. Early treatment, environmental controls. You were worried about whether I was going to cough now and spread TB to all of y'all.
The answer is all Russian doctors, TB doctors,
Right.
are saying the same because they don't want to have this barrier. And but all the time it amazes me. I mean,
But the other thing is that in fact, I think it is true. This gentleman was already so fearful about stigmatization. He just heard that he was HIV infected, and he was ready to die. And so I also think to put that mask in between the two of us is just
thank you for your
very
big
difficult
part.
to do.
So how old is this picture?
How old is this picture? This is one of my older pictures.
Okay,
So this is probably from 2002.
So is he doing well?
He's doing well. He's much heavier than I am now, okay? And actually back to work and went back to his family. It encouraged his wife to come and be tested. And so she was tested positive as well. But they're both in care and doing well at this point in time. Okay. So what do we know about TB and HIV? Okay. There is no clear data that said that patients with HIV have an increased chance of infection if exposed. Okay. We do know that patients who are infected once they're exposed have this greater chance of developing tuberculosis that we've talked about. So I've already said that in fact, if you have TB infection and you become infected with HIV, your risk of developing tuberculosis disease is about 10% per year. And in fact, a different study demonstrated that in fact a recent exposure does cause you to have a higher rate of going on to develop early TB than if you are HIV not infected. It just teaches us that in fact the cell line, the CD4 cells that are attacked by HIV are really quite critical in helping to control the early infection of tuberculosis. Now, patients who have advanced HIV have an accelerated course from infection to disease. Okay? If I'm healthy and have a normal immune system and become TB infected, 9 out of 10 of those individuals will never get sick. And in fact, the one who does get sick, only about a small percentage will get sick in the first 2 years after infection. That's like a stress test to your immune system. But the majority of patients will actually have that latent TB infection or be a TB carrier for years or even decades, waiting until something else occurs to change their immune system. Now, in fact, many healthy individuals do break down and develop TB disease. I think that we actually, as physicians and scientists, don't actually understand all of those factors in our normal patients, our normal, I hope you mean normal immune system patients. There really are many factors of nutrition, stress. In my small state, I'm from Rhode Island. I'm not sure if any of you know very much about the geography of the United States, but Rhode Island is the smallest state in the United States. We're only about 80 kilometers tall and about 40 kilometers across, so very tiny. We have a large number of universities, and in the 25 years of working in the state clinic in Rhode Island, I can tell you I've seen a TB outbreak in every university in our state. When does it happen? These are normal, healthy individuals. It happens at exam times. I can tell you every one of our outbreaks has happened during exams. Because what happens during exams? The same thing that happened when you were taking exams. You stop sleeping, you stop eating well, and you're under stress. So we don't, clearly understand what those factors do in a normal host. I think you heard from Dr. Tony Harries today, for example, about the intersection of tuberculosis and diabetes. Okay? So that many of our individuals may be TB infected for decades at a time. Diabetes comes in and is the driver to make them sick. Well, the problem that actually this study showed in San Francisco in the early 1990s, at the beginning of the HIV epidemic, is that in fact in very advanced HIV, and we classify advanced HIV by looking at the number of these CD4 cells that you have. A normal healthy person has about 500. Profound immunosuppression occurs when you have under 50. In this study that Dr. Daly did, he was actually looking at a hospice center for HIV patients, because this was before we had any antiretrovirals available. One patient moved into the hospice center with tuberculosis. They had not been diagnosed, got diagnosed 2 days later and moved out. Over the next 12 weeks, 15 more patients living in the hospice center developed tuberculosis, got sick, with the majority of them dying before care could be done. This was one of the first studies that they actually did epidemiologic fingerprints of the tuberculosis organisms from all of these patients, and showed all of these patients were infected by that one person. Okay? So what you can see is that the problem, too, with HIV is that you not only get sick more commonly with tuberculosis, but the more advanced your HIV is, the more rapidly you go from infection to disease. So it puts pressure on physicians like me to try to find those patients before something bad happens. Now, here's going back to Mara's question, is that if you can start highly active antiretroviral therapy for HIV, it still turns out that those patients have a higher rate of developing tuberculosis than an HIV-negative patient infected at the same time. So once your immune system is damaged, there's nothing that we know of as of 2013 that can bring that immune system all the way back to normal. Okay. Well, with that background, sort of understanding that people with both infections get sick much quicker, they get sick more commonly. What are the WHO recommendations for what we should be doing for all of these patients? And it's really bidirectional screening. All TB patients should be screened for HIV, and all HIV patients should be screened for TB. So this is pretty simple. We can sort of finish our lecture early, right, and go have an extra set of coffee, because it sounds like it should be pretty easy. Okay?
Excuse me, if you don't mind, may I take you back to...
Oh, sure, you can take me wherever you want to go with you. That sounds like a Kenyan name.
Yes, yes.
Yes, so I knew that you were my brother.
Oh, yes, absolutely. I apologize for being late and going
no.
this time.
Not to worry.
Yes.
I saw those lines too.
So one of the earlier speakers seemed to suggest that TB is not always diagnosed correctly in the US because it's so rare that most physicians have no idea what they're seeing when someone's infected.
Correct.
But you told us that every year almost you come across cases of TB. So are you one of the few doctors in Rhode Island who know anything about TB? Or?
Yes, I am, as a matter of fact. In fact, in the state of Rhode Island, there are 1 million people and there are two TB doctors. I didn't mean to interrupt you there. So.
No, that was my question because it seemed to contradict what the other gentleman.
Well, the other thing is you have to realize that just like in all of your countries in the United States, we have a TB control program. In my state, we have one TB clinic that serves the entire 1 million population, and it's me and one other doctor. So one of the issues for us is that we have lots of people referred in because they're TB suspects. And then because of my work, I just have a much higher suspicion than many people. But you're right, it is absolutely shameful. I live in the United States. We have good access, for the most part, to health care. I only have 50 cases of active TB disease in my state every year, although we treat about 3,000 TB infected individuals so that they can't get sick. And every year for the last 5 years, I've had someone die of tuberculosis. And it is always because somebody didn't think about the diagnosis. I just have to take one side and tell one story. What I think is actually particularly shameful in my system of a failure of the system, I had a colleague who was an ear, nose, and throat doctor. He was born outside the United States. His mother died of tuberculosis when he was small. And he, as a hospital worker in the US, he was supposed to be screened. He had a positive tuberculin skin test that he thought was related to his childhood vaccination in his home country. So he got friends to sign off his paperwork every year. Okay, you know where this story is going. Okay, he was a smoker. He started to get sick and lose weight and had hoarseness, and he self-diagnosed himself with a head and neck cancer and said to his partners, I know this is a terrible diagnosis because I take care of it all the time. I want to just finish out my life doing what I enjoy. As he got sicker and sicker and sicker, even his patients became worried about him, and he collapsed in the office, was taken to hospital, had advanced tuberculosis, and died 2 weeks later of drug-susceptible tuberculosis in the middle of our hospital system. So you're absolutely right. The problem where I live with my Gates at the university, you missed that picture, but people die because they don't think about tuberculosis. Where I work in Kenya, people die because of lack of access to care. So the problems are different in different places. So let's go through those WHO recommendations. So we should screen for HIV in all TB patients, okay? Because in fact, one, they need treatment for their tuberculosis, but two, they'll need treatment for their HIV. And that also gives you a sense of what kind of urgent timeline you're on in terms of doing your care. So theoretically, this should be pretty easy, okay? I'm not sure if you have ever seen that HIV test, point of care test done, but in fact, it's just like a diabetes screening test. It can be done in any spot. You just prick the finger for a spot of blood, put it on a special tablet of paper, and wait 3 minutes, and you have a yes/no answer. Okay, very easy to do. Those tests are very, very inexpensive now. They're very sensitive and specific, meaning they pick up HIV very easily, and they're not false positives. Okay, so it's a test that's not wrong. Okay, the only false negative is actually from the, just like with tuberculosis, from the day that you actually become infected till when the test can pick that up, there is a small window period of weeks to maybe 2 to 3 months. That's the only place where these HIV tests don't work well. Now, in fact, it's a one-time test that can be done anywhere unless you have HIV risk factors. The testing should be done early in care, and it means that someone is antiretroviral eligible. So it should be easy, so we won't have to talk about that. Well, I took off the WHO website last night some of the HIV testing rates for the countries where I knew some of y'all might be from, okay? And in fact, in the Stop TB Symposium that I know you didn't get to go to today, I was over there, but globally, about 47% of TB patients get tested for HIV, globally. And you can see that, in fact, the difference, there's a large variation of difference of how commonly that test is done in different places of the world. Now, so why are the testing rates so low? Okay, availability of test kits. That is true that in much of the world there has to be a supply chain to be able to get these test kits to where they're needed. And again, I work with Winkle in Kenya. I'm not sure where you work. I work in Eldoret. The big city. I'm the country girl, sorry. But out in Eldoret, we sometimes have problems with having enough test kits. So that could be a problem. Now, for a long time, it was thought that you really needed a highly trained counselor to ask the patients about testing. And so when we first started a lot of our HIV testing in the TB clinics, both in Rhode Island and in Kenya, the problem was that we didn't have enough people who were trained as HIV counselors. Now the current recommendations are any healthcare worker should be able to discuss HIV testing with the patient. Stigma, even though antiretroviral therapy and care is so widely available, many people still don't want to talk about HIV, don't want to talk about why they might be at risk for HIV. So stigma is still a problem. Now, I can tell you though, in my experience at the places where I have worked for many years, both Rhode Island and Kenya, it's the reticence of the healthcare providers. We're usually the people that are more afraid of talking about HIV than the patients are. Okay? We're the ones that sort of don't want to really talk about the risk factors for HIV, or we see someone who's I used to be able to say my grandmother, but now I'm old enough, I have to say maybe my mother's age, and I don't want to actually have to talk about HIV testing with them because it implies that they've had a sexual life. you know, and that maybe I didn't want to really talk about that with someone who was my mother or grandmother's age. So, in fact, I think it's really reticent of healthcare workers. In our Rhode Island TB clinic, we just published an article about 2 years ago. We introduced HIV testing into our clinic for every patient who came in, performed by the nurses. Did a survey of the nurses beforehand, and they said, oh, no one will want them, we'll drive people away. Once we started doing this, 99% acceptance. People said, oh wow, I can be tested today and know before I go home? Why would I not want to know that? And really the same thing happened when we were setting up HIV testing in the Eldoret area. Everyone in 2000 in Eldoret knew someone who died of AIDS. Everyone knew that the epidemic was there. And it was really the moment we started saying, we can test you, and here's the clinic to be treated at. There was no barrier there. So I think we often don't think about the reticence of healthcare providers in addressing some of these issues. So the diagnosis of tuberculosis in HIV patients. So I said, okay, for the TB patients, we need to actually diagnose if they're HIV infected or not. For the HIV patients, we just need to be doing lots of TB screening, right? Well, this is a little bit more difficult for a variety of reasons. As we talked about, there was exposure, infection, disease, contagion. So the problem in tuberculosis is we have some tests that look for TB infection. We have some tests that look for TB contagion. We have other tests that might look for TB disease in other parts of the body, because you're only contagious if you have pulmonary disease. So as opposed to HIV, it has a finger prick test that I can do in 2 minutes that says yes or no. I don't have that in tuberculosis, okay? For TB infection, we can do what's called a tuberculin skin test. It's a test that's actually, I don't know, has anybody ever seen a TB skin test or had one? Okay, so some people, but it's a test where you actually apply a small injection to the arm, and then 48 to 72 hours later, someone's got to look at the arm and, you know, decide if it's positive or not. So there's a lot, you can already think of a lot of the logistics there. You know, I've got to get you to come twice. They have to be 48 to 72 hours apart. What do I do on a Thursday? You know, my clinic isn't open on Saturday and Sunday. So lots of problems. There are new tests called interferon gamma release assays. Again, it's a fancy name for a blood test that does the same thing that the skin test does. Okay, it just looks to see if you've been infected with the germ. So this is a cheap test that can be done in the clinic. Okay, costs about $1 a test. This is the very fancy way to do it in a reference laboratory, and at least at my sites, it costs about $75 a test. So it's just not an easy way to look for latent TB infection, because that's what we'd like in our HIV patients, right? We'd like to find them when they were infected, get them treated then, wipe out that chance that they'll get sick. For TB disease, we actually even have a problem, because you think, oh, well, it's easy at least to make the diagnosis once people are sick. But in fact, there are two different types of tests that we might use. It's called microscopy. Is when you take a sample from the patient, usually their sputum or their spit, to look under the microscope and see if you see the TB germs. Sounds pretty simple. It is pretty simple. It can be done in a matter of a couple of hours. But the problem is tuberculosis mycobacteria are very tiny. So in a half a spoonful of spit, you have to have about 30,000 organisms to be able to find it under that microscope. Okay? So that's called being smear positive. Okay? The technician can see the organisms on the smear of the sputum. And those are the patients that are contagious. So I have one test that tells me that people are contagious. But if you don't have 30,000 organisms and half a spoonful of spit, then the only way I have to look for TB disease is to put that specimen in a bottle, in a culture, and wait for it to grow. This method takes about 12 weeks. Wow, that's a problem, isn't it? I just told you earlier, if you have advanced HIV, you can be dead in 12 weeks before I would ever know, okay? So that's a problem. Now this machine back here is a special piece of equipment where you can actually, instead of doing the culture on solid media, you can do it on liquid media, and it's about a week, okay? But I can tell you we were one of the 5 diagnostic centers to try this out in the developing world. You can do it, it's not easy, you know. We have a triple backup system for electricity because if this thing turns off, everything is gone. So lots of problems like that. So here's the problem in the diagnosis of TB and HIV patients is just not easy. Okay. The other issue is that tuberculosis is the great masquerader. In our HIV patients, it is more common for them to develop tuberculosis outside of their chest. Okay? When we talked about, remember our little 4 terminologies: exposure, infection, disease, contagion. Pulmonary or lung tuberculosis is what's contagious. It can be diagnosed by that microscope slide, okay? That's what most control programs look at because it's the public health issue. And in HIV negative patients, 80% of tuberculosis is in the lung. So it's easy to find there. But in fact, tuberculosis can cause disease in any part of the body. Doesn't matter whether I'm in Kenya or if I'm in Rhode Island, I see TB of the eye, TB of the brain. Tuberculosis of the female genital tract is the most common cause of infertility in the developing world. You can see TB of the spine, TB of the kidney, TB anywhere. That's more common in our HIV patients. And so you can think about, it's easy to get spit out of patients. It's hard to get bone, kidney, other places for you to make that diagnosis, okay? Smear negative, that early tuberculosis form where I said you don't have 30,000 organisms in a little half a teaspoon of spit, is more common in HIV patients. And that window of opportunity to diagnose tuberculosis is shortened. So lots of challenges in making the diagnosis for TB and HIV. This trial actually shows you even more problems. Okay, so if I can't get specimens from patients in terms of spit or something to look under the microscope, the other way that we commonly look for tuberculosis is through a chest radiograph. Okay. This was a trial that was done in Tanzania that was actually screening people to then enroll them into a TB vaccine trial. So they were looking at HIV positive patients, okay? They had moderately advanced HIV. Their CD4 count was under 200. Remember, a patient without HIV is normally 500. Advanced HIV is under 50. So these were moderate. 14 of them, as they came in out of that 93, they had TB. It was easy to pick up when you talked to them. 4 of them had what we called subclinical tuberculosis. They had no symptoms when you talked to them. They didn't think they were sick. Their chest x-ray was normal. They got all of this screening because they were going for a trial, okay? They were going to volunteer for this trial. So 4 of them had subclinical TB, and then another 6 of them These were AFB smear positive, so when you looked under the microscope, you could actually already see the germ under the microscope. These 6 had no symptoms, and they had such early TB you couldn't see them under the microscope. But this just shows you the challenge of how do I do screening when you come in and you feel well? You know, I can't even, you know, depend upon symptoms in this population at times. Now, this is the algorithm that's been developed through a trial. It was done in Cambodia, Thailand, and Vietnam of, well, how do we want to do TB screening in HIV positive patients? So traditionally, the symptom, did I pull somebody out? Sorry. The traditionally, cough was always the symptom that we actually looked for. Cough for greater than 2 weeks, cough for greater than 2 weeks. This is written on the soul of every TB doctor around the world as that's who you want to go check for TB. Well, it turned out that they found that what we had always asked didn't help. It didn't pick out people who were sick, and it didn't pick out the patients who were sick, and it didn't pick out tuberculosis. It just picked out people who coughed. They had asthma, they had pneumonia, they had all kinds of things. And so, in fact, what they actually did find for HIV positive patients, the questions that you should ask to try to screen are cough of any duration, even a day, combined with fever of any duration, and then night sweats. So we've been doing a lot of studies to try to clinically figure out if I'm running a big HIV clinic, the clinic that we work in Eldoret, Kenya right now, we've enrolled 160,000 HIV positive patients. WHO says I should be screening them every time they come in. So what this is trying to do is to find a way for us to screen in some type of reasonable manner, rather than saying every time you come in you need a chest x-ray, 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 you need a sputum, you need a sputum. We at least have a questionnaire that we can ask. Will help to pick it up. Okay, so we've talked about screening for TB and HIV. So in TB patients, all TB patients should be screened for HIV. Theoretically, shouldn't be difficult. Point of care test. HIV patients should all be screened for TB. This is quite difficult, I think. After 25 years, I still find it difficult. If one of y'all have a good way of doing it, please come and help teach me. And the problem is that in the TB patients, you only have to test them once if their HIV risk behavior isn't reoccurring. But in countries where all of us are living and working in an airborne disease, our HIV patients remain at risk for tuberculosis forever until we bring down the incidence of tuberculosis in your community. So you need to screen them over and over. So lots of challenges there.
Quick question.
Sure.
Is the gene expert making a difference?
I think, so you heard about Gene Expert? Did everybody?
I think someone talked about it. Right?
Okay.
This is the espresso machine.
Okay, yes, I was gonna say, that makes me feel good that other people describe it the same way. So
Several.
that's how I describe it, is, it's a little coffee machine, you put your little coffee pack in it and click it, and in 90 minutes it says TB, or not TB. And it says, do I carry the gene for MDR, for TB resistance? We've been rolling out Gene Expert in our area, in Western Kenya. It is quite helpful in terms of picking up those patients we've been using it for the patients who are smear negative, okay? So what we were doing in our HIV patients and in our HIV not negative patients, we did this first because this test, smear microscopy, costs pennies. And then we've been doing Gene Expert. So we have found that if you have cough for 2 weeks, about 10 to 14% of our patients will be smear positive. And then another 9% will be expert positive. So we also, in our first project, we're doing culture on all of those patients. So we found the same 9% were culture positive. But our problem was, this took 12 weeks. This took 1 to 2 weeks. Expert takes 90 minutes. Now, though, what's the challenge? Because there's always costs, right? Okay. These slants can be made for about 50 cents a piece. It did turn out that our rapid culture, when we calculated up the cost, it cost about $21 for the culture. Okay. When we started our expert project 18 months ago, a expert coffee cartridge, to put in the machine, cost $18. Now, what Cepheid has made the commitment globally to do is when they hit sales targets, they drop the price. So the price is now dropped to $9 per cartridge, and they have made a commitment that it will get to $5. They probably won't drop it below $5. So we think at the rate that Expert is taking off, that will actually drop to $5 by maybe, the end of 2014. The Expert does have some issues, like this. You've got to plug it into something. In one of our distant clinics, we've actually found that we run it off solar power. Okay, and some other projects are running off solar power, so that's pennies. And my technician would hate for me to say this, but I can run the test. I know how to put the coffee thing in the coffee machine and hit the button, and I can read yes and no. So you can actually have use our technicians to do much more elaborate testing, and so it's not quite the cost. Darn, I should have brought a picture of my expert test. So let's just talk quickly about some treatment issues in TB and HIV. So you would think, wouldn't you, that if I was talking about TB and HIV, you'd say, of course you want to treat TB, and of course you want to treat HIV, so what is there to talk about, right? But in fact, we've been spending a lot of time talking about treatment of TB and HIV over the last decade in both the worlds of TB and in HIV. Now, I'm not sure how much you've heard about the regimens for tuberculosis, but drug-susceptible tuberculosis can be cured with a 6-month course of antibiotics. For the first 2 months, called the induction phase, you take 4 drugs. For the last 4 months of the continuation phase, you take 2 drugs. Okay? So TB treatment for disease is 4 drugs, no matter where you are in the world, at least. Antiretroviral therapy is at least 3 drugs. That's the initial regimen. In both diseases, you need multiple drugs that attack the pathogen in different ways so that they can't become resistant. Okay. Now, you can imagine then, it could be difficult if Clifton walked in and I diagnosed him today with TB and with HIV, and I go, it's okay, Clifton, because I can treat you, and here are 7 different types of medicines I'd like you to start tonight. Okay? And now we are lucky in most parts of the world because we have fixed dose combination medications, so that you might have, in Kenya, for example, I'm very lucky there because we have all 4 drugs in single tablets. Okay? And the same is true for antiretrovirals. It's not true at my clinic in Rhode Island. I have to give individual pills. But it's also, even if I have fixed dose combinations, I'm sorry, I'm not going to give you 1 pill for your TB and 1 pill for your ARV, because you know what, I think you're a little bit bigger than I am. Okay? And so your dose is going to be different than my dose, than our children's doses. So I'm talking about starting this new patient on 7 drugs, multiple pills, okay? And so you can begin to think about what the debate was over the last 10 years. Is it, do we need to start both of them today? Can we delay with some of them?
No.
Do they have overlapping toxicities? No. Well, what we can say is it's clear, it was always clear from that early study in the hospice. If you have TB and HIV, you can never delay the TB. It has to be started. What most of the debate has been is if you came with both diseases at once, can I delay starting your antiretrovirals, or does that have to be started immediately today? That's what the debate has been about. Primarily because of pill burden. Will people be able to take them all? Will people be able to tolerate them all? Of the first-line treatment for TB and HIV, if there's 7 pills, 7 pills. I can't even do my fingers right. 7 pills. 5 of them all have liver toxicity. And so can you imagine sort of trying to manage that, okay? So it was debated for a long time as whether you always had to start the TB early, because that you were going to die if we didn't do that. But we thought, well, maybe if you had some of those CD4 cells, we could wait a little while. If you were HIV positive but had a CD4 count of 300, could we wait a while? If you had a CD4 count of 2, could I wait a while? And so it was quite a bit of debate for a long time about that. Oops, this one. Now, in fact, is it necessary to treat them concomitantly? There's multiple studies now that demonstrate that if you delay the antiretroviral therapy till the end of TB therapy, it's bad news. People get other opportunistic infections, they get sick much quicker. So, in fact, that question has been answered right away. The last, I'm going to go past these, okay? So then the question is, we know we need to treat, but do we need to treat right from the very beginning? We now know from several large clinical trials, the earlier you start, the better, no matter what your CD4 count, but especially in those with very low counts. So people who have low counts under 100 would get started the same day, or very closely same day. After that, higher CD4 counts, you might be able to wait, but the current recommendation is between 2 and 8 weeks after you start your TB next. Okay? The other issue is actually all of the drug-drug interactions, but I'm not going to talk about them because I actually know I'm beginning to run out of time. But I'm just going to show you, these are really the tables where we look at how to pair the different drugs, just to show that it's not quite as easy as you might think. Okay? Then the one other thing to let you know of why people began to be worried for so many years about starting these drugs together is that, in fact, there was a complication called immune reconstitution inflammatory syndrome, or IRIS. I like to explain this simply in that if you had advanced HIV, we talked about how many of those patients actually presented with, when you screen them, they actually had no symptoms. They didn't think they were sick. Some of the reason they didn't think they were sick is that your symptoms of fever or cough or such are related to actually your body's immune system trying to fight the infectious disease that you have, in this case TB. So one of the things that we actually saw early in, I'm going to show this picture, in treating patients with antiretrovirals, often early in the course of their TB, or sometimes starting them on their antiretrovirals without thinking that they didn't have TB, is you reconstitute their immune system. And suddenly your immune system realizes, oh my God, I'm sick with tuberculosis. Okay? So in the iris syndrome, people will actually develop very high fevers or hectic fevers, or in fact can actually begin to actually very dramatically demonstrate that they actually have tuberculosis. Okay? Because all of a sudden your immune system says, oh my God, I've got to do something about this. So that when this was also part of the debate about when you needed to start both TB drugs and ARV drugs, because it was thought that if you started your ARV, your antiretroviral therapy early in the TB course, you might have this complication. It does happen at times. It happens most commonly when the patient is very immunosuppressed and you're putting them on antiretroviral therapy early, but it should not deter anyone these days from starting antiretroviral therapy early on in a TB patient. So just look at this. Now I can't remember what part of my lecture I was going to talk about for this one. So we talked about the WHO programmatic issues of WHO recommends TB screening for all HIV patients, HIV screening for all TB patients. The other part of the programmatic issues for TB HIV are called the 3 I's. Intensified case finding, that's the screening over and over again for both diseases. Isoniazid preventive therapy, trying to find, this is actually giving a single medicine, INH, to individuals who carry the TB germ but are not yet sick. We can intervene we talked about how you could intervene at that time period. And infection control. And we ended up talking about infection control because of your question about Russia and why I wasn't wearing a mask in my pictures. Okay, so I'm not going to go through these. This is the same screening. Conclusions. I want to give you some time for questions. So to treat TB and HIV adequately, the first step is improved diagnosis, and you have to think about it in both settings. And you're right, my training for physicians when I'm sitting in America is to remind them to think TB. When I'm working at my site in Kenya, I don't have to train people to think that way. So you have to think about what setting you're in. Concomitant therapy reduces mortality, and timing is the challenge. Iris, although it's a risk, it's never a reason not to start. And this very aggressive case finding actually has, and screening of people continuously, has more than one benefit. It's going to benefit you if I thought about screening you and diagnose you early. But if I also diagnose you early and get her on medications, I'm going to stop you from being contagious, and it's going to benefit Mara and Biswaji because they're not going to become infected. Questions? I've done lots of talking. I'm happy because, in fact, you did stop me along the way for some questions, but we're open for questions now, too.
Just, we were at the press conference just before you talked.
Ooh.
And
What was the press conference
now
on?
it's a revolution in the treatment of
MDR?
Yes, because now there is a short term which takes only 9 months of treatment. Did you hear anything about that, and what is attitude and what is your attitude to this?
Okay, I wasn't at that press conference. The union is involved in one of the trials to look at shortening the course from 9 months to 9 months from 22 months.
Yeah.
From 22 months. I would call that a mini revolution. We do need to actually figure out, does it work? Does it work for all patients? I think we're going to know that, I hope, over the next year and a half to 2 years when that trial finishes. But I don't know, you weren't in the Stop TB symposium today when the activists came in, our civil society. It would be a revolution, it would be a little revolution. I would call it a little mini coup if we can go from 22 months to 9 months. But in my mind, that's not really a revolution. A revolution will be when we go from 22 months to a week. When we go for drug-susceptible tuberculosis for 3 days. When we go to TB infection in 1 pill. Now you're right, you know, I saw you go. And I saw, oh gosh, you know. But in fact, that our civil society was actually over there telling us that today. That in fact, for TB, even the union is an organization that will be 100 years old in 2020. It is time for us to have a real revolution, and we really need to demand that. And I think that if we were talking about cancer in the developed world, we said, oh wow, we had a little revolution today. You know, we brought the cure rate of, you know, make it up, breast cancer from, you know, 50% to 60%. Everybody would say, what are you talking about? You made a little tiny improvement, but that's not a revolution. So I think it's good. It's not a revolution. There's my advocacy hat, okay? And I hope you'll see, I think at the opening ceremony, I'm actually hoping the civil society comes through again for one of their clear demonstrations, but it was quite good today. I tweeted about it, just so you know. I learned as part of the communications program this week, I'm learning how to tweet. And the Stop TB partnership already sent it out early this morning watching the advocates.
Unfortunately, we missed it. We didn't see this.
So sorry that
But we're here at the training.
This is very important. This is more important. You'll see it at another time.
Just to follow up on her question, it's all very well for activists to demand results now, and I've seen similar activism over HIV, they demand a vaccine for it now,
Right.
and so on. But realistically, I'm more inclined to share her view that surely it's a revolution if you used to have to take drugs for 2 years, and now you can take it for
No.
9 months.
I didn't
Especially
say,
as people stop taking them after some time.
well, I have to say, I didn't say it was a bad thing
No, you didn't.
to go from 22 to 9 months. It's just in my mind, I'm not sure it's a revolution. And I do think that we do need to take some of the playbook of our HIV colleagues. Okay. Why is there a point of care test for HIV? It might be a little simpler. You know, I'm not an immunologist. It might be a little simpler to develop, but than a point of care test for TB. But it was because there was a demand. That it was unacceptable to watch people die. It was unacceptable in the HIV population. It is just as unacceptable that anyone die of tuberculosis 50 years after we have an available drug. So I agree with you, Wycliffe. It's good. I wouldn't turn away a 9-month regimen, but we can't be. I just think we just can't stop there. Yeah. So I'm going to turn you into that.
Good luck with that. Who else has questions? I know this presentation was very clear.
I try to be clear. I actually, do you know, I'm sorry, I keep moving back and forth, and I'm sorry I tripped over your camera multiple times, but I actually find it a challenge to actually do the mid-afternoon post-lunch talk.
I'm actually, just including what the Gina was actually asking, right? do you actually believe that gene expert is the the one of the best methodology or kind of test kit which can help the TB patients?
I actually do. My experience is I think that it's actually quite amazing, and I think that it is going to make it is going to be our change in diagnostic. Wycliffe was claiming the 22 down to 9-month treatment regimen for MDR is. For example, I can just say that he lives in the big city. I live in the small city out in western Kenya. The only TB culture laboratory for care is in Nairobi. My specimens where I was worried about MDR-TB would go off to Nairobi, and no offense, they liked the big city and they never came. Okay? It took months. So, what we've been able to use with our gene expert is that in the last year, all 29 of our 29 MDR patients were diagnosed on the same day that they were in clinic at the first presentation because we had gene expert. So I think there is going to change that because those patients now are not going to go through 1 or 2 treatment regimens, and we're not going to wait months for that test. I also, I'm actually one of these believers in intensified case finding. That what we need to do is to actually do community-based finding of cases. I don't want to wait until Pradeep feels so sick that you come to me to get diagnosed. Because by the time that's happened, everybody in your class has been exposed and some of them are infected. I think I need to go to you. And so, for example, Linda gave the question about gene expert, and I said, well, 9% of our smear negative cases got diagnosed on gene expert, same day. So again, I'm getting people earlier and hopefully cutting down transmission. And I think that has to be one of the keys. We have to make the community safer for everyone to get in front of this epidemic. So that's where I think gene expert is going to be.
There are a few companies which are actually related to gene expert, the other diagnostic tests who are actually India. They were specifically contacted us and they were actually telling us that you are starting gene experts and there are so many things which cannot be detected instantly. It's just a coffee shop, coffee machine.
Yeah.
But do you agree with those things?
Yeah.
I think, Jordan, you have a question?
So far, do we have that kind of portable version of gene expert?
Well, when you say portable, it's certainly more. Well, it's certainly more portable than the laboratory. This one of the piece of equipment is pretty robust, and so in our program we actually move it from place to place on a car to monitor screening. It is not as easy to pick up as his iPad yet. It still requires. It's not totally portable. It is movable, and so it's robust enough, but it's not. It's still a lot to carry and move.
But at least it doesn't require a live environment to work, right?
No, you don't need any special infection control, so you don't need, when you look at that laboratory that I showed, there was a hood that people had to work under. None of that is needed. You basically need an electrical plug.
Ma'am, do you have a reluctance of private hospitals to buy gene expert because the profitability for them wouldn't be so much because the cartridges are so expensive? Do you see that problem?
I have to admit, I work primarily in the public sector. I am always amazed at how well the private sector can figure out how to make a profit. Okay? So I think that, no, I haven't seen the private sector use the cost of the cartridge as a reason why not to put one of them in their office and sell it to patients.
Do they do that all the time in Kenya? Or?
Kenya, I haven't seen it in Kenya, at least where I'm working in Western Kenya. I have colleagues in Nigeria who have told me that they have seen their people buy gene experts for private labs. Haven't had that experience.
Because they don't do that in India, so
Yeah.
they don't buy it, and it becomes a problem because a lot of private hospitals have, patients access private hospitals too,
Right.
but they don't have gene experts. So there is a dearth of machines.
Yeah.
We have time for
Dot
one more
centers they have
question.
in India.
What?
In dot centers, I mean, they have identified few districts in India where, this particular TB campaign is on. There they have got machines, but not whole of India, this problem.
Yeah. Yeah. I think in Kenya there's like, I believe there's 24 machines at the moment. So again, they're not everywhere. We've been doing a lot of logistics work. So we actually use motorbikes to bring sputum in from all of the surrounding dispensaries into our gene expert hubs. But yeah, it still isn't point of care like that finger prick HIV test.
All right, well, thank you so much. This was
Oh, well, thank you.
fabulous.
Thank you very much.